Coming up next on Being Well, Dr. Abdur Shakir, director of the Regional Cancer Center at Sarah Bush Lincoln, returns for a discussion about lung cancer. Dr. Shakir will tell us about the latest statistics, screening, and treatment options. That's just ahead on this edition of Being Well, so don't go away. Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. Additional funding by Jazzercise of Charleston. Welcome back to Being Well. I'm your host, Lori Casey, and today Dr. Abdur Shakir, the director of the Sarah Bush Regional Cancer Center, is here to talk to us about lung cancer. Thank you so much for coming back to Being Well.
Thank you for having me.
Well, let's talk about lung cancer. How does it rank in as far as cancers in the U.S. as far as death rates?
When we actually just look at globally, we find that lung cancer is a leading cause of cancer-related death in the world. Roughly 1.6 million people died last year secondary to lung cancer. When we go specifically to the United States, there was 220,000 cases that were diagnosed last year and 160,000 deaths. When we look at the gender specifically, we find that 87,000 men died last year of lung cancer and 72,000 women died last year of lung cancer. When we use that as a comparison to other cancers, more men died of lung cancer than prostate cancer, colon cancer, and pancreas cancer combined last year.
And that surprises me because I think a lot of the other cancers out there get a lot more attention, but lung is still huge.
Absolutely, and I think it's a major epidemic, and I think now it's become more into fruition of how do we decrease lung cancer rates in patients.
Okay, I know this is probably a very obvious question, but smoking causes lung cancer is the number one cause?
Correct. So 90% of lung cancers are secondary to smoking. There are alternative causes, but when we look at just the main causes, it is smoking that causes lung cancer.
And how does secondhand smoke fit into your increased risk of getting lung cancer?
It's very difficult to quantify how much secondhand exposure a patient or a person gets, but we do know that the number of lung cancer death rates secondary to secondhand smoke is about 3,000 cases per year. There's actually other reasons outside of secondhand smoke that I also warn patients about, and that's actually environmental toxins, one being radon. It's a colorless gas. It's naturally occurring in the environment, but how patients get radon exposure is actually through their homes. When homes were built or are built on uranium-rich soil or water or rocks, this uranium, after a certain period of time, converts into radon. And after a long-term exposure to radon, that's actually the number one cause of non-smoking lung cancer deaths. Roughly 15,000 people die. So people usually notice radon gas, usually at the time they sell their home or buy a home. There's a testing for radon then, and there are actually simple environmental test kits that can be done to look for radon.
Okay, but still smoking.
Yes, to make it clear, smoking is the 90% cause is secondary to smoking.
Well, let's talk about, is it ever, say someone has smoked a pack or 2 packs a day for the last 30 years and they figure, well, it's too late for me to quit, so why quit?
It's correct in saying that patients who smoke a pack a day for 10 years have something called a 10-pack year, or a 10 times risk of developing lung cancer than the normal individual. And when I hear that, or maybe if you hear that, you'd first think, boy, I better stop smoking. But most patients will think that it's too late. I've done this for 20 years. The results are going to happen already. But what I explain to a patient that there's certain things that happen to a body as soon as you stop smoking. So within the first 20 minutes, your heart rate and your blood pressure decrease.
20 minutes?
First 20 minutes of stopping smoking. Within the first 12 hours, a gas called carbon monoxide that builds up in your body begins to decrease. Within the first 3 months of stopping smoking, your lung function improves. Within the first 9 months, shortness of breath, cough improve. Within the first 1 year of stopping smoking, your risk of coronary artery disease and stroke cut by 50%. Within the first 5 years of smoking, the risk of esophageal cancer, bladder cancer, and throat cancer decreased by 50%. The first 10 years of stopping smoking, the risk of lung cancer decreases by 50%. So it's never too late to stop. And this is a common scenario that physicians tell me actually it's too late that they should stop smoking, or patients tell me. So that's a misnomer. Patients should stop smoking when they can.
Okay. So is it the same for if someone smokes pipe or cigars? Does that cause the same? Can that also cause lung cancer, or is cigarettes really the worst?
Great question. Cigar smoking and pipe smoking can cause different forms of cancer. They have a
Okay.
higher incidence of throat and mouth cancer secondary to cigar smoke. They have a lesser incidence of actually lung cancer, but that doesn't mean that they should continue cigar smoke or pipe smoke. Patients also think that filtered cigarettes are better or low tar cigarettes are better. That's just an advertising campaign that has nothing to do with decreased lung cancer
What
rates.
about electronic cigarettes?
That's actually helpful for a transition to stop smoking.
Okay.
Obviously, less tobacco, less nicotine. Ideally, we want patients to stop smoking overall.
So are lung cancer rates, do you think they're going to go down as like smoking rates are going down? So like when our age group that doesn't smoke gets to be 60, 70, will we see lung cancer rates go down, do you think?
The easy answer is yes, but how we got to this point was actually quite simple. If you just look at history, in the 1920s, tobacco companies, what they decided to do, and people smoked before the 1920s, but they started targeting men. They said, we're going to target men to smoke. And then in 1950, the number one cause of cancer-related death in men was lung cancer. The tobacco companies then didn't realize, or they probably did realize that, well, maybe we should cut back on tobacco advertisement, but what they did then target was women. They said, okay, we're going to start looking at women and targeting them for smoking cigarettes. And then in 1975, the number one cause of cancer-related death for women was lung cancer. Till 2005, the lung cancer rates have been increasing. But actually, as of 2005, there's been a 2% per year decrease in lung cancer death rates for men and 1% per women. So we've done a fairly good job at advertising campaigns. Everyone's seen the commercials. But I think we have to take the next step, and that is parents telling their children, teachers telling their students, physicians telling their patients, hosts telling their audience about the risk of smoking and lung cancer.
Is smoking increasing in younger populations, or is it overall going down?
The American population right now, roughly 20% smoke. What we hope for is over the next 20 years that we can bring it down to 10%.
Okay.
And then 20 more years later, hopefully closer to 0%.
Let's talk about the diagnosis and treatment. What are the basic signs of lung cancer?
So what I tell my patients and actually physicians is the first sign of lung cancer is actually a cigarette. If you see a patient smoking a cigarette, that's their first sign of lung cancer. But there's actually 5 symptoms that I go through with family physicians and patients. The first being cough. If you have a cough that's now changed in production, the quality of the cough has changed, that's actually the number one symptom of lung cancer. Roughly about 50 to 80% of patients will actually have this symptom. The next is something called hemoptysis, which is coughing up blood. That's an ominous sign that we do see in lung cancer patients, but it only occurs about 20%. The third is repeated treatments of pneumonias. So if you see a patient and you're a family doctor or you're a patient yourself that has now 3 treatments of pneumonia over the last 3 months, you have to start thinking, is there something else going on in the person's lungs? The next, or the fourth, is shortness of breath. It's a common symptom in lung cancer patients or in smokers, but when we see the shortness of breath now change, where they were able to walk to their bathroom without feeling short of breath, but now just getting up in the bed and they're now short of breath, that's a symptom that's concerning. And last is chest pain. Where the lungs are situated is actually by the ribs. The ribs are encapsulated in the lungs. When a tumor develops in that lung, it causes swelling of the lungs and it pushes up on the ribs, and it typically causes chest pain. People sometimes think they're having a heart attack, but it's sometimes actually different.
So how do you go about diagnosing or different tests to see, if someone has?
So it's typically a stepwise fashion. So if a patient presented to their family doctor with those symptoms, the usual first step is a chest x-ray. And if the chest x-ray does not show anything, which I compare to an old definition television, the next kind of ramp up would be a CAT scan. A CAT scan kind of is a higher definition picture of the lungs. And if that is found or suspicious area is found in the lung, the next step would then be a biopsy. And after a biopsy is performed, then we get an answer. Is this lung cancer or is this something different? And then they're typically referred to a cancer doctor.
Okay, we're going to talk about treatment in a little bit, but I want you to explain the 2 different types of lung cancers.
Okay, so there's actually 2 different types, and their main 2 types are something called non-small cell lung cancer and small cell lung cancer. Non-small cell is the most common type. roughly 85% of patients with lung cancer will develop non-small cell, and 15% will develop small cell. These days, we make a distinction for non-small cell as well, that we further subdivide them. Up until 2005, all cancer doctors would say either have non-small cell or small cell. But after 2005, we realized that there's more subsets of the non-small cell that are important. The first being is a non-small cell adenocarcinoma, which is the most common. Roughly 50% of patients with non-small cell will have this type. The second type is called squamous cell cancer. Roughly 30 to 40% of patients will have that type. The reason why we make that distinction is because the treatment is completely different for the two.
Okay, so how do you go about treating the two?
So with non-small cell lung cancer, there's actually 3 different ways to treat. One being surgery, second being radiation, and third being chemotherapy. If you have non-small cell lung cancer, all of those are your options. When you have small cell lung cancer, it's either chemotherapy or radiation. Surgery in about 95% of patients does not play a role in small cell lung cancer. When we talk about adenocarcinoma, the chemotherapy type is different, and when we talk about squamous cell carcinoma, the chemotherapy type is different.
Okay. So what are I know that does lung cancer, like other cancers, do they divide into stages?
Yes.
Okay.
So
at what stage is it typically caught?
Great question. So majority of lung cancers are found in the advanced stage, stage 3 or 4. So roughly about 75% of patients will be found in either a stage 3 or stage 4 setting. The classical staging of 1, 2, 3, and 4 is done for non-small cell. There is something called limited stage and extensive stage, which is only done for small cell cancers. So if it's limited to the lung, it's called limited stage, small cell. If it's outside of the lung, then it's called extensive stage for small cell. For non-small cell, the traditional 1, 2, 3, or 4, that means if it's 1, it's less than 5 centimeters. If it's 2, it's between 5 to 7 centimeters with an involved lymph node. If it's stage 3, it's any number, any size, but involving the lymph nodes near the chest as well as the opposite side of the chest. And if it's stage 4, it's outside of the lung. It's involving the fluid, the opposite lung, the brain, the bone, the liver, etc.
So why are so many of them caught in those later stages?
The reason being is typically small tumors or small lung lesions don't cause symptoms. The patient's rest of the lung is able to manage or to compromise with the other lung function. So usually what happens is till that tumor causes a problem, like it's involving a lymph node, or it's involving the fluid, or the opposite lung, or a brain, or a bone, till that symptom happens, most patients don't realize it.
So we talked before we start taping that now there is a movement to do high-risk lung cancer screening, to maybe catch it when it's in stage 1 or 2. Can you talk about how that's evolved and who that might impact?
Sure. So screening, who we do right now for patients and has had effect, is for breast cancer for women, colon cancer for both men and women, cervical cancer for women. Some would debate PSAs for prostate cancer for men. So there was a trial called the National Lung Cancer Screening Trial. This was conducted by the National Cancer Institute. What they did was they took 53,000 patients between 2002 and 2004. They divided the 2 patients into 2 groups. One group received yearly CAT scans for 3 years, and the other group received yearly chest x-rays for 3 years. And then they followed the patients for 5 years. And what they found was very interesting. You were able to reduce the lung cancer deaths in patients with early CAT scans by 20%. But there's a certain group of patients that should be targeted. And these group of patients are between the ages of 55 to 74 and have smoked 30 pack years. That's 1 pack a day for 30 years or 2 packs a day for 15 years. And these patients should not have lung cancer in their history. If they do have lung cancer in their history, we follow them a little bit more different. But these patients should be targeted and looked at for early lung cancer screening. We've actually just implemented this at the Sarah Bush Lincoln Hospital.
Okay, so is that then, you think, going to cut down on you'll see it in stages 1 or 2? Correct.
So if the reason why we want to see it in stage 1 or 2 is because the prognosis dramatically changes between stage 1 and stage 4 lung cancer.
That's what I was going to ask. Talk about survival rates for catching it at stage 1 versus at stage 4.
Okay. So when we're dealing with just stage 1 cancer and we look at 5 years, what we call as a 5-year survival rate, we know that 80% of patients are living at 5 years with stage 1. If we look at stage 2, 50 to 60%. If we look at stage 3, 20% are living at 5 years. And if we look at stage 4, less than 5%.
Okay.
So there's a dramatic difference between the two if we find a patient at stage 1 and 2 or stage 3 and 4. So it's important for us to, as patients or family members or even family care providers, to target and hone in on these patients.
So do you see then like this high-risk cancer screening being as common as like mammograms and things
Absolutely. I think now it's at the time where we have to absolutely consider it for these patients, that it should be as routine as a colonoscopy or mammograms. But what I don't want this to take a place of is prevention of smoking. I don't want patients to think, boy, if I still smoke, I can just get a CAT scan every year and be okay. No, still the number one way to prevent lung cancer, because it is a preventable cancer, is actually by stopping smoking and not smoking at all.
Let's talk about the treatment. What's a typical treatment plan? How does it work? What are some common symptoms, side effects that your patients who are dealing with lung cancer deal with?
So before we decide treatment on a patient, the most important thing, what you mentioned, was stage. And to determine treatment, we have to determine stage first. So based on what stage, then we can determine treatment. So for example, if a patient was a stage 1 cancer, that patient would be geared towards having a surgical operation. So those patients are more geared to how do we cut this area of the tumor out, and most of those patients do not require any chemotherapy.
Okay.
They're able to have the cancer cut out, and that's it. But it's a major operation. Going through the lung and the chest and getting to the lung itself and removing the tumor is typically a major operation and takes weeks, 4 weeks at least, to recover from that major surgery. When you have a stage 2 lung cancer, surgeon is typically involved still. We remove the tumor, but in those patients we typically give chemotherapy. So if you have a stage 2 lung cancer, they're going to get chemotherapy after surgery. And chemotherapy has its own side effects. Unfortunately, chemotherapy to the date for lung cancer in stage 1 and 2 is not a targeted chemotherapy. It's more of a shotgun approach.
Okay.
Is that not only do you kill the bad cancer cells that are there, you kill all the normal cells that are around as well. When you have a stage 3 or stage 4 lung cancer, with the stage 3 particularly, surgery is not involved. That cancer has then spread to those opposite side lymph nodes, and there's no reason to go in and do surgery in those patients. And those patients are typically treated with chemotherapy and radiation together. When you have a stage 4 lung cancer, usually surgery and radiation don't play a role. Those patients are typically getting chemotherapy.
So why is it that you often hear people who have cancer, maybe a different type of cancer, it spreads to the lungs? What is it about the lungs that cancer likes, I guess?
Well, other cancers such as colon cancer, breast cancer, esophageal cancer, one is that the lungs are large organs as compared to other organs that are there, and plus a lot of blood supply happens to the lungs. So how tumors travel is typically through the lymph glands or by blood. And that's where a lot of endings come through, is through the lungs.
Okay, so that's why you often hear people with cancer spreading to multiple areas in the lungs.
Correct, and one of them happens to be the lungs.
If you're talking to, there's maybe family members out there, or maybe a person suffering with lung cancer, what would you tell them if they're having a difficult time, and how can they manage it and get through it and hopefully survive?
So the most important thing, what I see as a cancer doctor's role in that scenario, is to determine what's a person's goal for treatment. So the first meeting with your cancer doctor is the most vital. So at that first meeting, you want to determine what's the goal of your therapy. Is the goal to try to cure my cancer, or is the goal to try to control my cancer to delay its progression? After that goal is determined, then we can push patients in a certain way. So if my goal is to cure a patient, if I got to carry them on my back, drive them to the office, we're going to try finishing up therapy for that patient. Versus if the goal is to try to control their cancer, there's a tightrope that the patient and I are walking on, and that tightrope is balancing quality of their life and quantity of their life. And that's where the importance of having your cancer physician available in town 24 hours, 7 days a week, to have those discussions on a repeated basis is what's important.
So does lung cancer grow quickly? Does it spread quickly?
So with the two types, one being non-small cell and small cell. Small cell has a tendency to grow quite fast. In those patients, if I saw a patient like that in my office, we tend to start things quite soon, within typically a week's time of some form of therapy. So small cell can grow actually very fast. It's one of the fastest growing cancers that we have.
Okay. Talk about survival rates I know that's the goal of any cancer doctor is survival rates. The earlier it's caught, the higher the survival rate.
Correct. So when we look at statistics for lung cancer, and I explain this to a patient by actually drawing a graph out, how we come up with statistics for lung cancer is this statistician actually puts dots on the board and says, stage 1 cancer, they have this, they've died at this time. Stage 1 cancer could have died 5 years down the road. The real question for a patient is, where does their dot fall? Are they going to, with their stage 1 cancer, are they going to live only 1 year? They're going to live 5 years? They're going to live 10 years? And unfortunately with patients is we don't know where their dot's going to fall. We don't know where they're going to lie. So I tell patients is we can look at those statistics of what I quoted for stage 1 and stage 4. But I have been treating lung cancer patients long enough to know that it's very hard to predict how long a stage 4 lung cancer is going to live or how long a stage 1 lung cancer is going to live. But it's really important to focus on the treatment, getting through treatment, and understanding what the goals of any form of treatment are.
And I'm assuming, just like any other in medicine, technology changes, medications get better. Are there new things on the horizon for lung cancer treatment?
Absolutely. So if we look not at stage 1, 2, or even 3 lung cancer, stage 4 lung cancer, where a majority of the patients are found in, there's been a whole slew of new treatments that are available. What we do at the Sarah Bush Lincoln Regional Cancer Center is if someone had a stage 4 cancer, we're actually looking for targets. The generic chemotherapy is used in about 80 to 90% of lung cancer patients, but there's a certain group of patients that have a target sitting on their cancer that we can switch the driver of what's causing their cancer off. So it's very important if you're a patient or a family member that if you do have stage 4 or even advanced stage 3 lung cancer that you discuss with your cancer doctor, have they looked for a target on my cancer? Because if you don't look for that target, you'll never find it. So it's important that we as physicians look for that target because it's a simple pill that can actually switch off the cancer.
Really? That's amazing.
Yes. So, and this has been well known at least since 2010 and onwards.
Dr. Shakir, we hear a lot of bad things about chemotherapy, what it does to the body, the side effects. Can you talk about how maybe that's changed a little bit?
So over the last 10 to 15 years, we've done a remarkable job on tailoring the chemotherapy for the patient. 15 or 20 years ago, that shotgun approach of using standard doses was used for everybody, and we did not have good medicines for nausea. These days, our medicines are fantastic for nausea, and what I try doing for my patients is that we try tailoring a dose that's right for them. So what I tell patients is that the best cooks don't follow the cookbook, that there's a standard dose that's recommended, but we look at the patient, we examine the patient, we see their other comorbidities, and then we make a decision of what's the best dose for this patient.
Talk to me about the role of PET scans. First of all, PET, what does it stand for and how is it used?
Positive emission tomography. So what it is a more sophisticated way of looking at cancer in general. So what we have now available at the Sarah Bush Lincoln Regional Cancer Center is the PET scan. So after someone gets diagnosed with cancer, even lung cancer, they typically have the chest x-ray and a CAT scan. So what we have available is this PET scan. What it is that we inject a sugar dye, and that sugar dye is supposed to go where areas of cancer is supposed to go at. So it's a very sophisticated way of looking and seeing where else cancer is hidden at. So we're able to examine basically anywhere below the neck to look for cancer. And it's a very good tool for a baseline for patients. So we get an idea of where their cancer is at the beginning, and then after treatment, where is their cancer at afterwards.
You've talked about the different stages. Is there a stage at which it's not treatable?
Great question. So in patients who are incurable, the discussion of balancing quality and quantity of life is an important discussion to have with a patient. And that's where the skill of the cancer doctor and explaining the goals to the patient of the therapy is placed in. So there is always a point, especially in stage 4, where you have to determine, does the risk of the chemotherapy outweigh what the benefits are, or the risk of any form of therapy outweigh what the benefits are? And does the person's quality of life get so affected that it makes no sense to improve their quantity of life? So that discussion is usually a lengthy discussion with your cancer doctor, but that discussion should happen typically at the first meeting. What are the goals of therapy? And then those discussions continue to go on, because throughout the courses of chemotherapy, some patients tolerate chemotherapy and are able to work full-time, and some patients are able to tolerate therapy, or unable to tolerate therapy, are able to do their normal activities. And then we have to make that discussion. is this therapy worth it for them? So that discussion is really important to have with your cancer doctor. And sometimes it's very open and honest to get a second opinion. If a patient says, boy, I'm not sure if I'm doing the right thing with this chemotherapy, I actually advocate it to patients who are unsure about doing something or not doing something, is get a second opinion, hear what someone else has to say.
So in these last few minutes, I want you to give our viewers out there a little bit of advice. What would you say to someone that, has maybe smoked for 20 years and have never, haven't seen those symptoms, but they might be a little concerned? What would you say to them?
What I would say is that lung cancer is a preventable cancer. 90% of the causes of lung cancer are smoking, and it's never too late to stop. We can see the risk of lung cancer deaths decrease by 50% for patients that have stopped smoking for 10 years. It's also really important that you go to a place where you can get the appropriate workup. The most difficult thing that we see in patients who are smokers is that there's a delay in diagnosis. Mm-hmm. The patients, the family, even the physician sometimes thinks the shortness of breath is related to their smoking, or that chest pain is related to the smoking, or the cough is related to the smoking. But if they're concerned, doing a chest x-ray or a CAT scan is harmless.
Mm-hmm. All right. Well, Dr. Shakir, thank you so much. We enjoy having you on our show, and we hope to have you back again.
Thank you.
Thanks. Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. Additional funding by Jazzercise of Charleston. Being Well is also available online at our YouTube channel, youtube.com/WEIUTV. Just look for the Being Well playlist. Here you can view current as well as past episodes.